Barbara. All good.
Okay.
That's you. Just get the mic down here.
Good. All set. Well, welcome this afternoon to our update on measles in the community, an unwelcome visitor. We're going to be talking about how to recognize measles in your patients. We're going to be talking about how to diagnose measles with PCR testing and with serologic testing. And most importantly, we're going to be talking about how to prevent measles, the routine immunization for our travelers, and also through prophylaxis for people who may have been exposed to measles. Many people will ask, why are we seeing measles now? We eradicated it in 2000, and essentially a couple of reasons. Number one, there's been decreasing immunization rates since the early 1990s. Also, there are selected populations of unvaccinated communities in states who may have high vaccination rates. Measles also is still very common worldwide. Just last year, there were 300,000 cases confirmed by the WHO, and we are all traveling more. People also are immigrating to our country, and we have people who are visiting countries in which measles has been endemic. So measles can enter our country very easily through visitors and through us traveling. So essentially, we have been seeing measles cases sporadically over the past couple of years. We had our large peak of measles beginning at the end of 2024. And currently, we have over 1,000 cases of measles in the United States as of May 8th, documented by the CDC. Most of these are in individuals who are unvaccinated. Approximately 96% of these people have been unvaccinated, or their vaccination status has been unknown. About 30% of these cases have occurred in young children less than 5 years of age. 13% have been hospitalized, meaning 126 people have been in the hospital with measles, and we've had 3 deaths. Looking at the map of measles cases in the United States, we know that we've had a high proportion in Texas, 250, and in New Mexico. And these states have actually had fairly good vaccination rates, but measles has just entered communities in these states in which there have been a number of unvaccinated and susceptible individuals. There have been a smattering of cases in California and Pennsylvania. Also within the area, we've had 2 cases in Maryland. There have been a couple of cases in Virginia, none in DC or West Virginia. And I actually have to thank you very much for your wonderful vaccination rates within the DMV area, which has kept us out of outbreak status. When we talk about measles, a very important concept to know about is herd immunity. And essentially, people who get vaccinated not only help themselves, but they help their community. They serve as a barrier to the risk for transmission of measles in susceptible individuals within that community. In order to establish quote unquote herd immunity, in other words, to prevent measles from causing significant transmission, greater than 95% of the population needs to be vaccinated. And that's very specific. It will vary for different diseases. So overall, our national average for measles is measles vaccination based on MMRs in patients in kindergarten for 2023-24 has been 92.7%. Does that matter? Yes, it does. We want to be above 95%. So Measles vaccination is highly variable by state and by communities. And you can have some states which have a high degree of vaccination, but there may be pockets or communities which are unvaccinated. So I will use my home state of New Jersey as an example. When you look at New Jersey, you can see there's a little blue circle that's in the New York metropolitan region, where about 96% of individuals are vaccinated for measles. Across the state, it's about 93%. However, there are some communities in our southern counties, Atlantic County, Burlington, Cape May County, where there are communities of individuals who are not vaccinated. So if a patient with measles was to enter that community, essentially we could see a rise in the number of cases. Essentially, within our region, we had talked about vaccination being very high. We're within 92 to actually 98% with West Virginia in terms of vaccination rates. So I do need to give a shout out to all of you for vaccinating our patients, which is becoming challenging at times, and for keeping us out of an outbreak situation. Wanted to talk a little bit about measles. Measles has a great business plan. It has been very successful for decades, and it's not going to change the plan. So essentially, the incubation period for somebody developing symptoms after onset of measles, that is the fever and cough, coryza, conjunctivitis, is about 10 days. Development of rash after somebody is exposed to measles is approximately 1 to 3 weeks, usually happens at about 2 weeks. So essentially what we'll see in the initial prodrome, 2 to 4 days before onset of the rash, is patients will develop fever, cough, coryza, and conjunctivitis, the 3 Cs. And, essentially this always occurs. A few days later, patients may develop Koplik spots, which are tiny spots compared to granules of sand on the buccal mucosa on an erythematous base. Following that, patients will develop the onset of the measles rash. Essentially, the Koplik spots are very evanescent. They may last 12 to 72 hours. So by the time the rash appears, the Koplik spots may no longer be present. An absence of Koplik spots does not rule out a diagnosis for measles. The measles rash actually is a beautiful rash. It's our prettiest rash in infectious disease. It's a red rash, the rash that you never want to see. It's a red rash. It's erythematous, macular papular, starts as discrete lesions, begins on the face, spreads downward and outward. That's the business plan. That's the characteristic. It's not going to vary. Unlike patients with Rocky Mountain spotted fever who have rash which begins on the extremities and spreads inward, essentially measles always will begin on the head and face. The other thing I wanted to mention here is many times parents will call you and say their child has a rash. They'll be unable to describe it to you over the phone, won't know where it started, will say, well, I'm going to watch or track it. Have them take a picture. Have them take several pictures so you can watch the progression of what's going on. These are pictures that they can even email to you, and they've been very helpful to us in terms of following patients. What will happen with time is that these lesions can coalesce. And you can see a generalized picture of erythematous coalescing macular papular lesions. Patients with measles do not feel well. They have conjunctival injection, they have photophobia, so they're going to be squinting. They're not going to like the light. They often have arthralgias. They're not going to want to move around a lot, and that's what sort of gives them the measly type appearance. Okay. If people ask for reasons to vaccinate, one of the reasons I would vaccinate is the complications resulting from measles. It's not just a pretty rash with fever, which goes away in a few days. There are significant complications. 1 out of 5 patients who have measles are hospitalized. 1 out of 20 children with measles will develop pneumonia and require hospitalization. 1 in 1,000 measles patients will develop acute encephalitis, which often results in brain damage. 1 in 1,000 will die, and 1 to 3 children out of 1,000 with measles will die from pulmonary, such as either bacterial infection or measles pneumonia, or neurologic complications. We also have a business plan for measles. And essentially, if you have a patient who calls you up and says, I think my child has measles, there's a number of things that you can do. Okay. First of all, you want to get as much information as you can over the phone. This may be an appropriate time to schedule a telemed visit. You can get a chronologic history. You can see the patient, see what's going on at this point in time, and make a decision. During COVID, many of our practices would triage patients in the parking lot. They would obtain cultures, like swab them at that point in time, and that be something you want to pursue. However, I want to caution you, a rule-out measles patient is infectious, whether they're in your parking lot or in an airborne isolation room. Anybody who approaches these patients should be an immune healthcare provider who's wearing an N95 mask or a PAPR that's been fit tested. So if the patient comes into your practice, what you want to do is put a mask on them. Regular surgical mask is fine. Put them into a private room. And essentially that is sufficient. If you have an airborne isolation room, that is even better. You're going to want to call the Department of Health to get recommendations regarding testing and isolation, and we can speak a little bit more about that, and manage patients with supportive care, and we'll speak about that in detail. Measles patients are highly infective. We'll talk about how infective they actually are. And what is infectious about them is the respiratory droplets. So if they sneeze, cough, even if they breathe, those are the infectious materials. People are infectious from 4 days before the rash to 4 days after onset of the rash. The rash is essentially day 0. The other important thing to remember is that virus droplets will remain in the air 2 hours after a patient leaves a room. So if you have an isolation room, a measles patient has been in there, you need to wait 2 hours before you put another patient in that room because the droplets are infectious for that period of time. In talking about, just how infectious is measles. If you had a room with a large number of people inside, and let's go back to COVID, in which we were very concerned about infectivity. So if you have a room of susceptible people who have not had COVID, not been vaccinated, and you bring in somebody with COVID, you can infect maybe 3 people, okay? On the other hand, if you have that same room of people and who are susceptible to measles, who have not been vaccinated, you can infect 12 to 18, so 6 times as many. However, if 2/3 of those patients are vaccinated, the number decreases to 5. If 95% of those patients are vaccinated, less than 1 patient will become infected. Okay. In terms of infection control, we talked about putting a mask on the patient, putting them in a private room or an N95 room. We talked about the fact that the healthcare provider needs to be immune from measles and to wear a fit-tested N95 mask or PAPR. And we talked about the infectivity rate. Essentially, the reason you want to call your Department of Health is they can be very helpful to you in terms of knowing what's going on in the community, directing the care of that particular patient, and speaking about what you want to obtain from the patient. Typically, we do most of our testing and diagnosis of measles by PCR testing. And this is NP swab, preferably. You can get a throat swab, better to get both of them. You can also send urine for PCR testing, but not urine alone, urine in concert with NP or throat swab. We also want to get a measles IgM antibody. And essentially, if it's within the early days of illness, if it's within the first 3 days and it comes back negative, the patient still has a rash, then you'd want to go ahead and retest that patient. The health department can be very helpful to you. In some cases, they have told us to send a patient home. They'll go to home and test the patient, but that's not, something that happens in a large number of cases. They're helpful in that they know the cases in the community. You can also feel free to call us. When I was taking outpatient call, I think it was in early April, there were 2 cases in Virginia that were bona fide and identified. The practice called and said, we want to know what your recommendations are. And I said, well, I would recommend that you initially call the health department because they may help you in this management. And they said, well, we did. And they told us to, what their recommendations were. And they said, but we just wanted to talk to you to make sure that you thought the same thing. So we're always happy to talk to people. The health department has been great. They have exceeded all expectations, every single health department, and they are your ally in this. Okay, so we talked a little bit about how to obtain these swabs. One thing I wanted to just mention is when you send the PCR swabs, you want to send them in viral transport media or universal transport media, and not just, in the fluid that we would use for a throat culture or something else like that. Okay. So treatment of measles. There's no antiviral therapy for measles. The measles virus is susceptible to ribavirin. There have been no controlled trials done with this agent for measles, and the FDA has not licensed it. However, if we had an immunocompromised patient with measles, we would obtain an emergency IND and use ribavirin. Medical care is supportive. It's symptomatic relief. If there's a superimposed bacterial infection, obviously we would treat that. The World Health Organization recommends vitamin A for all patients diagnosed with measles, regardless of where they live. And so it's recommended on day 1 with a second dose given 24 hours later. Okay. So in terms of vaccine efficacy, measles is one of our MMRs, one of our most effective vaccines. 1 dose is 93% effective at preventing measles. 2 doses are 97% effective. That leaves about 1 to 3% of individuals who can develop breakthrough infections, but these are usually milder infections with less tendency to spread. Preventing measles. A lot of people have said, where should we focus our vaccination efforts? Vaccination should be giving everyone their routine recommended immunizations and then making sure they are up to date on measles before they travel, and ideally by 2 weeks before travel. We have a number of people who call us and say, I'm going to a region that doesn't have measles. I'm going here, I'm going there, I'm going with a private plane. The bottom line is, if you are leaving the United States, you need to be up to date on measles, regardless of how you are getting there. So 6 to 11 months of age, 1 dose of MMR, and then when the child reaches their first birthday, 2 doses given at least 28 days apart. Patients 12 months of age and older, the 2 doses at least 28 days apart. And for our teenagers and adults, 2 doses of MMR 28 days apart. Okay. When someone calls you and says they think their child has measles, the first thing that you want to know is, what is the patient's immunization status, or that the patient has been exposed to measles. Have they been received an MMR? How many doses have they received? Were they at least 28 days apart? You want to ask about their travel and exposure history. Where had they been? How long had they been there? Were there any ill contacts? Also, you want to know about the characteristics of the rash, where it started, where it spread. If you have somebody who calls you and said, my child developed fever and a runny nose this morning, and now at dinner time has a rash, that's not measles. Remember, business plan, 2 to 4 days of prodrome prior to the onset of the rash. You can look for Koplik spots in any patient presenting with a severe viral respiratory infection. Again, absence of Koplik spots does not rule out measles. And if you have somebody who's been discharged with a viral respiratory syndrome, you want to observe them for later development of rash. Okay, post-exposure prophylaxis. This is a very valuable table in the current Red Book. It's on page 675, and it tells you what to do for people who may be exposed to measles. The reason I like it is that it's very specific. It determines recommendations based on the age of the patient, based on the patient's immunization status, and the number of days after exposure to the measles case. And this is a very valuable guideline. So we have reviewed some of the aspects of recognizing patients with measles, performing appropriate laboratory testing, with PCR being the real workhorse in this. We also want to look at measles IgM serology and importance of preventing measles. And again, I'm thanking you for the third time for the wonderful work that you're doing in immunizing our patients, making sure that people who are leaving the United States are up to date on their immunizations, and extending prophylaxis to those who may be exposed. Thank you very much.
Thanks, Barbara. We have a short break after this, so we do have time for a question or two. I know there's been a lot of measles conversations over these last couple of weeks and months, but thank you, Dr. Jantausch, for packaging it so well. Introduce yourself and use the mic.
Hi, my name is Lucy Suarez. It's nice to see a lot of my mentors from Children's here. Thank you so much for your wonderful talk. This is actually not a measles related question, just a vaccine related question.
Sure.
With the updates to the COVID vaccine recommendations for children, I'm wondering how we should approach as primary care providers questions from parents about whether they should continue vaccinating their children against COVID. I've been asked this by several parents and mom friends, and I'm having trouble answering that question because of the new CDC guidelines. Thank you.
Yeah. We are all having trouble answering that question. What I would say to do it at this point in time, I think that there's going to be a response to the vaccination policy. I think you're probably going to get direction from the AAP and some other agencies, like if you want to have a specific, front line to go for them. The other thing that's important is they said, if there are individuals who have special needs, or that place them at greater risk for developing COVID. So certainly I would advocate for those patients, your patients who are immunocompromised, your patients who may have diabetes and so forth, things like that. But I do think more specific guidelines are going to be forthcoming.
Yeah.
Thank you. Christina Anderson, Mary Center.
Mm-hmm.
About the travel outside the U.S., I have been routinely immunizing the under age 1.
Yeah.
But one thing I hadn't thought about were those kids who were under age 4 and haven't had their second MMR. What is your recommendation on that?
I think it depends on how much under age 4 they are. But if they're traveling outside of the country and they've had 1 dose of MMR, you certainly could give a second dose 28 days apart. And I think I would base it sort of on how close, but you certainly would want to have to optimize vaccination before they leave.
Thanks.
Last question.
Yes.
Hi, Armina Rahman,
Mhm.
from Clarksburg, Maryland. My
Sure.
question is for these college students who are going overseas. They've had 2 vaccines,
Mhm.
but we've had some scared parents, and I've checked titers. and Some of them are not
Mhm.
adequate enough.
Mhm.
Should we be checking titers on these kids who are going for a semester abroad or something like that and getting some boosters?
No.
Okay.
So the current guidelines are not to check titers, and there are certain criteria to determine somebody to be immune. One of them is that they've had 2 MMR vaccines. The other thing is, while we don't know what people will run into abroad, there's been no recommendation from the CDC about a 3rd MMR dose in the case of an outbreak situation here. There are other things that they would do. For example, people who are born before 1957 may be required to have a 2nd dose and so forth. But so far, there's no recommendations on checking titers due to the efficacy of the vaccine.